So greetings everyone on behalf of VIROC, and we are grateful for with SICOT Shoulder Society to participate in VIROC Global. I have a short welcome address for the society on behalf of Bombay Orthopaedic Society. Bombay Orthopaedic Society is a 56-year-old society, and we are organizing this VIROC Global this year in 2022, where more than 68 societies are participating, and we are grateful to all of them. I am the organizing secretary along with Dr. Vishal Kundani, who is the organizing secretary, with Dr. Sangeet Gawale, who is the organizing chairman. And the meeting is happening in Mumbai city in Maharashtra, India. These are the Bombay Orthopaedic Society executive members who have helped in organizing this mega event with us. We all welcome you and thank you for your participation. With this, I hand it over to Dr. Daniel Moya for further proceedings. Over to you, Dr. Daniel.
Thank you very much, Dr. Ashok. It is a pleasure to be here with you and with friends from all over the world. We will have a session on glenohumeral instability. We will begin with Dr. Erika Colin from Indonesia. She will speak about glenohumeral instability classifications. Then we will go to clinical and imaging evaluation with Dr. Ashai Kekapture from India. Then our chairman, Dr. In-Ho Jong, will speak about principles of management for anterior shoulder instability. He's from Republic of Korea. From Canada, Ivan Wong will give us a lecture about lateral shed procedure. Then our friend Guido Fierro from Colombia will show us his experience on iliac crest bone graft. And finally, I will speak about multidirectional instability from Argentina. Dr. In-Ho, please, if you want to give an idea of what is our group and what are we doing in SICOT, would be great.
Hi, thank you, Daniel. It's a great privilege to be guesting Society of VIROC Global today. I'm particularly interested because this is very aligned to our SICOT principle, because we are always pursuing the diversity. Diversity by means we can get the wisdom and truth. So you will hear all different experience and build up your own experience by listening these different experiences from different continents. Thank you very much for inviting us. Thank you.
So, well, let's go ahead with this session. Erika, please, if you can share your screen, and thank you for participating. We feel that the first step is always to have a general idea about a general context of what we are speaking about, and especially in glenohumeral pathology, to have a strong classification will give us the chance to make better diagnosis. Thank you, Erika. Go ahead.
Okay. Thank you, Dr. Daniel from Argentina. I also would like to thank Dr. Ashok from the VIROC Global for inviting us to this wonderful virtual conference. So my talk is rather a warming up for this mega discussion about the glenohumeral instability. I'm Erika from Indonesia. Let's start. Okay. Shoulder instability is a very long recognized problem, since the description of this method of shoulder reduction by Hippocrates. Despite this long-standing problem, I feel that the definition and consensus of the classification is not clear. As the result, there is a long, winding debate regarding the management. For example, let's take a look at this. Different authors define instability in different ways. Even in the same textbook, the blue arrow represents the textbook from Dr. Madsen. So at least we can see 4 different definitions of glenohumeral instability. And here is the other textbook by Dr. Warren, same publisher, but two different instability definition. I think to avoid confusion, the definition should be very clear, accepted universally by me and you and other before the disorder can be classified. When we look at a patient who's suspected to have a shoulder instability, pain as a symptom may always confuses me, at least how to make a diagnosis. For example, if I ask myself, does the patient with a painful labral tear have instability? And does this thrower patient with shoulder pain, but he got no sense of abnormal glenohumeral joint, have a subtle instability? Okay, and as there are many disorders in the shoulder capable of producing pain, I think pain should not be used as a symptom to define instability, but a clear definition of instability would be one where patients have a sensation of their shoulder as loose, going out, or slipping. I admire Dr. Charles Neer, of course. He is a pope in shoulder surgery. Historically, but the medical literature regarding the instability has a number of flaws. First, most studies in the literature up until now is the procedure-based, not a condition-based. As a very popular example is the landmark study in 1980 by Dr. Neer on MDI. In that study, Dr. Neer included patients with different features of instability, yet the patient had one common procedure, the inferior capsular shift. When a paper is a procedure-based, it may include so many different populations who receive one same treatment. Instead, papers should be condition-based, which with the same population with a specific well-defined constellation of features is collected. And let's say 2 or 3 treatments are compared. As a result, I become more confused, and I think some of us perhaps may have this confusement. We do not have a clear definitions of glenohumeral joint instability in the literature, and the papers tend to use a potpourri of descriptive terms, which unfortunately are well received by most of us. These problems leads to the heterogeneity in the literature, making comparisons of different treatments difficult and meta-analysis nearly impossible. Because of the wide variation in the definition of the MDI of the shoulder in the literature, there is a wake-up call article in the JBJS aiming to decide if this variation influenced the distribution of diagnosis in a cohort of patients with shoulder instability. Dr. McFarland used 4 classifications. I think these are popular to classify this cohort with the MDI and adding a laxity test as a criterion for diagnosing patient. The study demonstrated that the variations in the criteria used for the diagnosis of MDI significantly affect the distribution of the patients with the diagnosis. So when you use a laxity test, it tends to overestimate the number of MDI. This observation is important because the results of the studies may vary if the patients with traumatic instability are considered to have MDI just because of the positive laxity testing. So until the criteria is clear, investigators or researchers will not be able to contribute in a compelling way to understand the condition, since they cannot know whether studies are comparing apples and oranges. Let us remember some popular definitions regarding instability. Sulcus sign, very popular, is a dimple created beneath the acromion when the subject's arm is actually traction down, usually in a seated position. This is very popular as a hallmark test for MDI by Dr. Neer. Although Dr. Neer reported that all of his patients had symptoms of instability with the sulcus sign, it is many of us now interpret a positive sulcus sign with or without symptoms only as a sign of inferior instability. It doesn't mean the patient have MDI. Another very popular definition in 1987, the dead arm syndrome by Dr. Carter Rowe. Looking at his paper, many of his patients were aware that their arm were slipping. Others were not. But Dr. Rowe considered all of those patients to have instability and performed an instability surgery to treat them. This picture is very typical, showing a very typical position for elevation and external rotation in which the arm goes dead. However, many of Dr. Rowe's patients had signs and symptoms for bursitis, biceps tendinitis, nerve impingement, cervical spine refer pain, and thoracic outlet syndromes. As such, it is not clear if these patients really have instability. So coming back to the definition, I think we have to have two common themes in the definition, which are symptoms and translation. Because we know that many patients have symptoms, especially pain, without instability. We also know that laxity tests can be existed in many patients without symptoms, and some can sublux their shoulder without any symptoms. Therefore, these two elements have to be together to define instability. Patients must have discomfort and feeling of loose, slipping, or shoulder going out to meet the definition of instability. A good classification should be simple, easy to use, accurately describe the different types of instability, reliable, reflect patients' perception of the disorder, and predict natural history and maybe possible treatment. This is a systematic review, identified 18 different proposed classifications of the glenohumeral instability. Yes, we have 18, which use different criteria. The frequency with which different features are used is presented. So far, we have etiology, direction, severity, and frequency as the most commonly used features. And Dr. Kuhn in 2011 introduced this system, the acronym FATS, to classify the glenohumeral instability, which later developed as a classification that can predict the likelihood of having surgery and perhaps to provide a prognostic insight. The FATS use the patient-reported outcome as a criteria for diagnosis. Frequency is an indirect measures of severity of the pathology, can be solitary, occasional, and frequent in a year. Etiology is also derived from history, can be traumatic or atraumatic. The formally described microtraumatic instability will be classified as an atraumatic subclass. Patient also may be able to tell you the direction of their instability or which position of the arm will reproduce their symptoms. For example, hand behind head for anterior or carrying a briefcase for inferior. Provocative tests will be performed if patient cannot tell the direction. Severity is determined by history. If a patient never has to require assistance to have their shoulder reduced, they will fall under the subluxation subclass. The classification had a good inter-observer agreement because I think it is highly dependent on the history and perception of the patient. Unlike the physician-derived criteria, which highly depends on the examiner skill. Okay, this is the example of the flow of the FATS classification. So while it is very extremely useful and easy to utilize, the classification does not really direct us to the appropriate treatment. So this is the MRI of 3 different patients with the same age, 17 years old, suffer from a first-time dislocator that were able to be reduced by the first trial. The first patient is not a professional athlete. The second and third patient are the professional athletes. If I use the FAT system to classify this instability, it means solitary, traumatic, anterior, and dislocation. They have the same classification. However, most of us, or at least us, will recognize that each case should be treated differently. Perhaps I will vote case A to be likely to improve with therapy. Case B might need a labral repair. Case C might need a glenoid reconstruction. So in light of this reason, the anatomic lesion should always be considered in the current classification. Take-home messages is, we should involve academic institutions and subspecialty societies as the logical groups and to bring the relevant stakeholders together to develop such consensus for discussion, ratification, and validation of this topic. I think this is my topic. Back to you, Dr. Daniel.
Thank you very much, Erika. It was very clear, very interesting point of view, and it gave us a lot of concerns about if we are all speaking the same language when we are discussing about instability. I will give the chance to discuss. I don't know if there are some questions or some different points of view. We should, I think, in the future, think about having one of the 18 as the best one for our committee. What do you think, Inho?
Daniel, I think that is really good idea because whatever we name it, we will accept all different way. So terminology-wise, we have to have a same picture in our mind so that we can make a right decision for our patients. So I'm going to talk a little bit about that instability and laxity issues because a lot of patients have a wrong diagnosis, eventually have a wrong, treatment. So I think that is absolutely necessary. We need to make a reasonable, algorithm or terminology setting. Thank you.
Good, thank you. You know that I think back in 2005, there was an inquiry for the members of the American Shoulder and Elbow Surgeons Society, and there were some questions related to classifications, and most of the people that were involved in that questionnaire conclude that there was not a perfect classification, and that they would accept a new classification that was adopted by the society, even if they disagree with it, because they realized that there was a very important need of at least having a common classification. Time has not shown a solution for that. I think things are getting even worse because each society is trying to develop its own consensus, and so we have many different classifications coming up every year. One of the important situations, or one of the important features to check to have a diagnosis and put the patient in one of the boxes of the classification, of course, and the most important is the clinical evaluation, but we know that images are very important also. And Dr. Ashai will talk about that, and for sure this will give us another important tool to advance with this topic. So Dr. Ashai is from Central India, and he will give us information about this.
Thank you, Dr. Daniel. Thanks a lot. I'm very grateful for this opportunity to express my opinion. And thank you, Erika, for adding to the topic. It's really a very confusing thing, but I hope to bring some light with the tools which are at our disposal, the clinical and the radiological consideration in the instability of shoulder. I'm Dr. Ashay Kikatpure. I'm Associate Professor and Unit Head at NKP SIMS Nagpur, located in Central India, and Director of Apex Specialty Clinics in Nagpur. So the introductory part regarding the dislocation has already been covered by Dr. Erika in quite detail. Mostly anterior, so I'll just brush it up. Mostly anterior, more than 95% of the dislocations. Posterior dislocations are about 3%, less than 5%. True inferior dislocations are less than 1%, and habitual non-traumatic dislocation which may present at multidirectional dislocation due to generalized ligamentous laxity and is painless. So, as pointed out, because we are struggling with all the other and multiple, I mean, a gamut of confusion. So the clinical examination and the radiological examination can give us an effective treatment plan. Why? Because we are dealing with the power generators, which are positioning the shoulder in the 3D space, resulting into a force transmission. So establishing a kinetic chain. And whenever instability happens, there is a breakage in the chain. And most of the times, all of us are treating patients who are athletes who have got an angular velocity of close to somewhere around 7,300 degrees per second, where all the major muscles are acting, and there is a lot of angular momentum in them. So instability in them will be different than someone who is a sedentary worker. So the assessment, the clinical examination, though the test will be the same, but the impact and the treatment will change. And about the deceleration, there is about 750 newtons of distraction forces occurring at deceleration. So the injury and the instability will be different. And we have to deal with the Thrower's paradox while stabilizing the shoulder, because it needs to be lax enough to allow excessive external rotation as well as stable enough not to dislocate the joint. All these accelerations in different ways will be having associated lesions, as pointed out by Erika. So they will have Hagel lesions, they will have Glad lesions, they will have Alpsa lesions, they will have bony Bankat lesions, and other nomenclature lesions. But in all, what the patient wants is a stable shoulder. So I'll just brush it up, the Madsen classification. So we need to really have our questions right. Okay, what are our questions? What are we going to ask? So history of previous dislocations. Whether the dislocation was because of a major trauma or a minor trauma, and what is the range of movement? How was the dislocation? Did it occur in sleep? The spontaneity of dislocations, whether the patient was aware of the hidden subluxations, and the history of dead arm. They will point us towards the hidden pathology in shoulder, and then subsequently we can find out what exactly we are dealing with, whether we have to really only a scopy will help or open procedure is required. And what are the red flags? History of a very high velocity trauma, tenderness, pain, restricted movements, abnormal mobility, dislocations in sleep, and MDI, of course. The physical examination part, we need to inspect swelling, wound scars, sinus, muscle atrophy, asymmetry, tenderness, strength of the deltoid and the rotator cuff, and the scapular stabilizers. Is there any obvious muscular atrophy? Then more extensive motor sensory and disturbances that can suggest a brachial plexus pathology. Whether the patient is having increased passive external rotation with the arm at the side and reduced external rotation in 90 degrees of abduction, that may indicate a medially healed Bankart lesion. We need to see the Brighton criteria for the global tissue laxity by examining the glenohumeral translation and the hypermobility of other joint. The apprehension test is the workhorse. When the pressure is applied on the posterior aspect of the humerus, on 90-degree flexion and 90-degree external rotation abduction, the patient feels some amount of apprehension. And if you put anterior pressure on that, downward pressure, they reassure. There is a surprise test which has been said to have a 99% of specificity once you suddenly remove that arm, and that can give us a clear indication in clinical examination about anterior instability of the shoulder. So the subluxation part, shoulder in 0 degree of abduction, one hand on the scapula, we grasp the humeral head with the other hand and apply a compressive force and check for the amount of anterior and posterior translation. Easy subluxation of the shoulder indicates the loss of glenoid concavity. The sulcus test, pulling the extremity distally, observing for sulcus or dimple on the shoulder that doesn't reduce on 45 degrees of external rotation. Now, grade 1 is subluxation less than 1 centimeter. Grade 2 is 1 to 2 centimeters. And grade 3 is more than 2 centimeters. Subluxation at 0 degree of abduction indicates rotator interval laxity. At 45 degrees, indicates inferior glenohumeral laxity. Arm in 90 degree forward flexion, anterior rotation, we check for the posterior subluxation and test for instability. Similarly, for the anterior instability, and we grade it as grade 1, 2, and 3. Now, in radiographic evaluation, though we have got CT scan, but the patient seldom comes with these X-rays now with you with a dislocated condition, unless it is a chronic condition. Someone has already relocated it. So we need to have a straight AP radiograph in external rotation, the straight shoulder in internal rotation, a Gaussian view, which will give us idea about the scapula, the axillary view, the Vernaghe view, which will give us the glenoid profile in the anterior posterior direction. You can see in the figure B, after relocation of the shoulder, there are loose bodies, and there is a small inferior glenoid bone loss. Okay. D is posterior dislocation, which is missed in most of the cases with a anterior Hill Sachs, and this is a luxio erecta after a car accident. So X-ray has its role in diagnosing dislocation. Posterior dislocation is most of the times missed on X-ray evaluation. So for that, we need to do CT scan. These are the other views in which how they need to be taken for the general audience. This is the axillary view of the shoulder taken in X-ray beam is projected through the axilla with the shoulder in 90 degree of abduction and the plate above the shoulder. It gives us a clear visualization of the humeral head with no superimposition and the relationship of the humeral head to the glenoid. You can assess for the glenoid bone loss anteriorly as well as posteriorly, and the assessment of the acromion and the coracoid process. This is the West Point view. The patient is lying prone. It's a modified axillary lateral view with shoulder abducted in 90 degrees and elbow bent over the arm hanging over the table. The X-ray beam is directed 25 degrees medially and cephalad. It shows calcifications or small fractures at the anterior inferior glenoid rim. The striker notch view, patient in supine position, elbow elevated over the head, is directed 10 degrees cephalad. It shows Hill Sachs lesion and the Vernaghe view. It helps in measuring the distance between the anterior and the posterior glenoid rims on the anterior posterior axis. So, but now this has been a lot supplemented by the CT scan. So multi-detector CT scan, it helps us to evaluate the bone defect and bone loss and to evaluate the type of lesion, subsequently helping us decide the type of surgical intervention which is going to need needed. So as you can see, a posterior Hill Sachs lesion, anterior bony Bankart, and an engaging Hill Sachs. So Hill Sachs lesion in this can obliquely oriented in the neutral view, which becomes parallel on the anterior labrum in the abduction position. And sorry, excuse me. So basically, we can determine the amount of bone loss with the PICO technique, with the CT scan or the multi-detector scan, by centering the central circum method, and by calculating the amount of bone loss. So the percentage of bone loss can be calculated by this formula. A is the surface of area of the best circle fit. B is the surface of the contralateral glenoid. And then about the glenoid lesion of the Hill-Sachs and is lateral to the medial margin of the glenohumeral tract. The medial border of the off-track Hill-Sachs lesion overpasses the medial margin of the glenoid tract. C shows the articular loss and a total articular measurement. This concept was very well explained by Professor Yamamoto, in which the glenoid bone loss on the on-track on the off-track lesion, and thereby we can supplement it with lethargic. Speaking about shoulder dislocation, we need to be aware of the concept of glenoid tract with the arm in various degrees of abduction, maximum external rotation. Okay. So, am I audible? Excuse me.
Yes, Ajay. There was a problem with your voice, but now it's perfect.
So Professor Yamamoto described the on-track and the off-track lesion based on the location of the size of the humeral defect and the amount of bone loss. It has a very high predictive value in clinical settings, determining the type of surgery that will be needed. If it is more than 19%, 19 to 20%, we have to do a bony procedure to supplement the loss of glenoid. If it is less than that, a soft tissue procedure with a remplissage will help. Off-track lesions can result from either a large bony Bankart lesion or a Hill-Sachs defect, or from combination of a moderate size Hill-Sachs and a moderate bony Bankart. The two factors determining the lesions are the anterior inferior glenoid bone loss and the Hill-Sachs interval. Hill-Sachs interval is the addition of Hill-Sachs defect per bony bridge between the rotator cuff attachment and the lateral aspect of the Hill-Sachs defect, and it is measured in the axial plane. What are the implications? What is the implication? If the Hill-Sachs lesion stays on the glenoid track, on-track lesion cannot engage the glenoid and cannot cause dislocation. On the other hand, a Hill-Sachs lesion which is out of glenoid track, which is off-track lesion, has a risk of engagement and can result into dislocation. The area of Hill-Sachs lesion can be measured on a CT. Coming to this MRI resonance imaging, it is the workhorse and the most sought after treatment. There is some debate about use of gadolinium for assessment of the capsular tears, but as you can see, it can very well show you the amount of Hill-Sachs. And then this is a capsular lateral complex which can be easily evaluated on the MRI, and you can see the different types of lesions: the anterior labral lesions, the Bankarts, the Perthes, the ALSA, and the GLAD lesion very well on a MR orthogram. So now MRI orthogram is the gold standard. Coming to the humeral avulsion of humeral side of the capsulolabral tear, it helps in understanding the posterior band, the inferior glenohumeral ligament tears, the tear of the axillary hammock, and the from D to F, you can point out on the MRI the various MDI associated lesions of the inferior glenohumeral ligament tear. At the same time, it gives you an idea about the posterior labral pathology, the posterior bony osseous lesions, the Kemp's lesion. It is a concealed lesion of the posterior labral complex. If we miss the Kemp's lesion, then and only operate on the anterior Bankart, there are 85% chances of recurrent instability. With this, I would like to say that instability is a complex scenario where you need a combination of a clinical and radiological assessment. MRI being the workhorse, but still the role of X-ray and CT scan is there. CT definitely to understand whether the lesion is on track and off track, and make a proper call for the treatment. Thank you.
Thank you very much, Dr. Ashai. It was very complete panorama of diagnosis, clinical and radio imaging diagnosis. I don't know if someone wants to add. There is little to add, but does everyone want to say something or ask? Yes, Erika.
Oh, yeah. Thank you, Daniel. I want to, I'm just curious. Ashay, your talk is very nice. Despite the best fit circle, the Huseman and the CT 3D reconstruction, I'm sure you all measuring this bone defect. And then when you do surgery, you saw the bare spot there, and do you still measure it intra-op, and will it affect you in a way?
A very good question. The answer to it is that it will, all the decisions which we go inside with are pre-operative. I will like to give it enough thought in the pre-operative area, and then my decisions won't really change. If I have decided to go ahead with the Bankart repair after measuring the glenoid defect, then I have decided, I've calculated the bone loss, and then my decision doesn't change inside.
Okay.
Good. Well, we have evaluated our patient in India. We classified the problem in Indonesia, and now we go for treatment to Seoul. In show, we will give you an idea of different options, treatment options to manage these patients.
Thank you, Daniel. Good morning, good afternoon, good evening, ladies and gentlemen. I'm In Ho John, and again, I'm very delighted to be involved in this VROC meeting. And first of all, I will congratulate 56th Annual Congress of Mumbai Orthopaedic Society. And once again, thank you very much for giving us a chance. Today, I would like to talk about anterior shoulder instability, the principles of management, how we manage it. So again, I would like to emphasize this. Instability is different from hyperlaxity. Sometimes you are confused this instability with the hyperlaxity, so you advise a wrong diagnosis and wrong treatment to the patient. So this is two complete disease entirety, so we have to keep in mind. And then as we have more elderly people in our society, and we have more and more people over 60s who's got shoulder dislocation. So I would like to say, you guys, we have a two bimodal pattern of shoulder dislocation in the very teenager and elderly, but the pathology in these two groups are completely different. So now let's have a look at this 18-year-old guy, patient who had a traumatic shoulder instability. He reported he's got 3 different shoulder dislocations, and this is the plain x-rays he took in the emergency room. Now, after closed reduction, you can see a little bit of a defect on the posterior superior part of humeral head, and glenoid defect is not very much significant. So this is the MRI. So as you can see here, you see the labral tear, which has not been much displaced. And I will say this is a pretty much a linear labral tear. It doesn't really belong to the glad or the ARPSA or some other lesions. So what other issues would you like to propose? We took the CT scan and then evaluated this humeral head defect. And this is in our definition, it's not really a huge severe defect. I would say this is a very mild humeral head defect. So what is your treatment? What would you like to suggest to this patient? So here's the instability severity score. This patient is younger than 20s, then score 2. And he's not any active athlete, so recreational sportsman, not much of contact sport, so the score is 0. And the shoulder hyperlaxity, no. And there's a small heel sulcus, so not visible on external rotation, and glenoid contour is good. So overall, if you add all these, the score is less than 6 points, then you can anticipate a good surgical outcome with the arthroscopic stabilization. So this is the arthroscopic view from the anterior superior portal. As you can see, the labral detached from the glenoid. And then again, this is a very straightforward arthroscopic procedure. It's got a little bit of a tear here in a superior labrum, and heel sulcus was not very wide. So we did arthroscopic stabilization of the labral repair. We tried to make some of the labral bump in the front, and we tension the anterior inferior glenohumeral ligament. So here's a question. Do you think the arthroscopic Bankart surgery gives a 100% success? If it is not, what is the cause? In what sort of situation we should be careful? So we had some analysis in our arthroscopic failed Bankart surgery between 2010 and 20. So when we analyzed them, most of the failure were from the surgical errors, either fixation issue or pathology issues. Because the surgeons, they put the anchor screw too medial or too proximal, so do not have a secure fixation anterior inferior. And obviously, if you have excessive capsular laxity, there's always a chance of recurrence. So this is a very typical picture you can see for our revision surgery. The surgeon who operated this patient had a anchor screw very superior at 2 o'clock without putting any anchor screw 5 or 6 o'clock. And again, here you can see the metal anchor very medial to the glenoid neck. And if you have this anchor very medial to the glenoid neck, what happens is it's like a Perth lesion. The glenoid labrum heals very medialized, and you cannot expect any tension anterior inferior. Just obviously you can expect the recurrent shoulder dislocation again. So glenoid tract has been very well addressed by Dr. Ashay Kekapre and Erica Collin. So I'm going to skip this, but still in my clinical practice, I'm very selective and careful choosing patient for remplissage surgery, because this is a good example. Before Bankart repair, you can see the heel sulcus lesion, and it looks like almost engaged. But once you repair this Bankart lesion, then you don't have any more anterior translation, and then this posterior lateral is not more engaging lesion anymore. So if again, I would like to emphasize this: heel sulcus lesion is the consequence of shoulder instability, not the cause of the shoulder instability. So I will focus more on the glenoid side, the labral capsular complex. So this is 25-year-old traumatic anterior shoulder instability. He brought his MRI because he belongs to the army. So as you can see here, there's some lesion in the anterior inferior glenoid side. So what would you propose? So we took the x-rays. As you can see here, there's a heel sulcus in the posterior superior humeral head and anterior glenoid. Very suspicious of some defect. So are you happy with these images, or would you like to do anything more? So we had a CT scan, and as you can see, this is this MRI, and this is same patient with the CT scan. And it's very interesting. If you have this 3D CT, the CT much clearly shows you a big glenoid defect. So if you suspicious any of glenoid bony defect, don't trust the MRI that much. Sometimes MRI gives you a wrong information. So whenever you are suspicious of glenoid defect, always a CT scan is the best tool to give you to measure the bony defect. So humeral head deficiency of 25%, glenoid deficiency about 25%, then obviously you will agree the arthroscopic stabilization will create more recurrence rate. So what about the open stabilization, open Bankart? I know not many surgeons now prefer to do open Bankart surgery. This is why I would like to introduce this open Bankart procedure with you. Open Bankart is not simply repairing the labrum. You can actually do more of this labral repair. In my mind, open Bankart is a capsulolabral complex reattachment and capsular shift and retensioning of capsular ligament, so-called capsular plication together. So now let's have a look how we can do this open Bankart. We do use a low anterior deltopectoral approach, as you can see, conjoined tendon and pectoralis. So we dissect the lateral part of conjoined tendon, and then this is a subscapularis. We elevate subscapularis from the capsule. Then now you can see the capsular incision is ready. So we dissect more to the medial side, and it's easier to dissect on the medial and distal part. We make a vertical capsular incision, and then we are ready to expose this glenoid bony glenoid Bankart lesion. So we debride this all scar tissue, anterior, inferior, all the way down to the glenoid neck, and then make a bone tunnel to pass these sutures. And then we can have one matrix of stitches. So the knot is now behind this capsule, and possibly we can have a very good contact between the capsular labrum and the tension of the capsular labral complex. Now we finished the capsular repair, and then it's time to do a capsular shift. So on the medial side, the capsular labral ligament has been repaired, and then by making knots, then we readjust this capsule to the lateral side. This is important. At this stage, you need to keep your arm at least 30 degrees of external rotation. Otherwise, you will lose your external rotation. So this is how we do open Bankart surgery. So, ladies and gentlemen, I would like to say anterior capsule is not a plastic rubber structure. Anterior capsule is a very living, viable tissue with a lot of mechanoreceptor and free nerve endings. So if you have a repeated shoulder dislocation, this anterior capsule becomes pathologic. So you need to shift anterior inferior capsule to the front so that they can resist a proper stretch force in the front. However, the problem of this open Bankart procedure, if you make a too tight anterior capsule, you know what happens? Let's say you would like to rotate the arm externally. If you have a very tight anterior capsule, you have a more shear force in the back of the shoulder joint, and you do more external rotation with the tight, and then obviously humeral head will subluxate with a more shear force, and this is eventually create uneven wear of glenoid, and this is a so-called dislocation arthropathy. So too much tight anterior capsule can create this harmful complication of dislocation arthropathy. So whenever I meet any patient with a recurrent anterior shoulder dislocation, these 4 factors are special situation. Patient has any glenoid insufficiency, then you need to think different way. Is the patient contact athlete, or patient has a suboptimal compliance because of any neurologic disease? Was this a revision surgery? Then soft tissue is a completely different scenario. So in my clinical practice, any stiffness, cuff defect, MDI, especially the voluntary habitual instability, is not a good indication for open Bankart. Still in our clinic, open Bankart result is very successful with good return to sports, and patient satisfaction is very high. So ladies and gentlemen, I would like to finish my talk with this slide. If you are thinking about the shoulder instability surgery, there's actually two different types. One is anatomic reconstruction, which is a Bankart. The other is non-anatomic reconstruction, either Bristol Latajet or Adinhibit, which will be covered by Dr. Guido Fierro later on. And this instability severity score sometimes give you a very good predictable guideline so that you can refer in your clinical practice. Thank you very much.
Thank you very much, Inho. It was very clear. I want to welcome Dr. Christos Koukos, who is based in Germany and is a member of our committee. And is there any question for Injo?
Yes, I have a question, Dr. Moya.
Thank you.
Go ahead.
Yes, I have a question about the anchor in the most inferior position, because if you use the anterior portal, I mean, you cannot put the anchor perfectly at 6 o'clock. You put like 5:30 or 5, okay? But when do you decide to use an accessory portal to put the anchor at 6 in the right direction, not from anterior for posterolateral? When do you decide to use that portal for that anchor?
Oh, Fierro, it's very good, interesting topic, because I always try to put the anterior inferior 530 anchor screw as low as possible. But before putting that anchor, what I really would like to do is to release the capsulolabral tissue all the way to the 6 o'clock so that I can pull this capsule all the way to the superior and the laterally. So in my mind, capsular shift and then proper tension of the anterior inferior glenohumeral ligament is essential. So once you have a good tissue back to the 530, I don't think this 530 or 6 is really important. So maybe the tension is more important than the location. But in my slide, what I saw in all the failure cases, they put the anchor 2 o'clock or 3 o'clock without putting any screw to the 5 or 6. But Dr. Guido, if you have any good trick to put anchor at 6 o'clock, please let me know. But what I usually do is curved guide, and curved guide, all such anchors can give you additional help. What do you think?
Yes, I mean, I decide about the size of the tear. If the tear start at 6 or anterior to the 6 hour, I don't use the accessory portal. But after release, of course, after release, if I saw that the lesion is at 6 or more posterior, just a little bit more posterior, I put the anchor in the other direction from an accessory portal, because I really you need like a stop, like a point of fixation in that position. I completely agree about with the tensioning of the capsule, of course, but I think when you have a tear from the 6 or posterior to the 6, you really need to put an anchor from the other direction and have a strong fixation at that point.
Ivan, you have any insight?
There is a, if I can say something, like there is another with a 530 portal, what Imhoff from Munich actually describes, and he does it actually quite often, but I don't use it because I mostly do lateral decubitus. But in the beat chair position, it's in lateral decubitus is really, really dangerous because you can actually injure the axillary nerve. That's the thing. And I use lateral decubitus, but it's not the case though in the beat chair position. I totally agree with you, Inho, that you said it's the whole point is to free up the capsule, and then you can do your shift. Doesn't matter if it's 5:30 or 5 o'clock. It just has to be okay in that position at the end of the day. And what I do actually the past 2 years, in the meantime, I always augment. Because I totally love the principle of the augmentation, especially what I mostly do is this ASA, the Arthroscopic Subscapularis augmentation. And it's the whole principle that what it's all the augmentation techniques, I think, on the anterior side are based on it, because what they do, like, it's the kind of a sling effect, what we know from the lateral Z technique, where the subscap doesn't go upwards anymore, and at the same time, this CHL, it stabilizes the anterior inferior migration, actually gets augmented. That's the same principle does the dynamic anterior stabilization. The same thing with the interval closure as well.
Yeah, Chris, I think that you can talk a little more about that after Ivan Wong's talk, because Ivan is going to talk about the LATAZ, and then we can talk more about the dynamic stabilizer.
Yeah, I'm going to be in the UR in a bit, but I hope I'm gonna be there.
Ashai, you have a question?
No, I want to add to this concept of anterior dynamic stabilization when he is augmenting the subscap. What I have been doing in some of my patients is augmenting with the biceps. And I have been using those cases in some of my chronic dislocation patients. And we have a series of 2-year follow-up of 7 such patients with chronic dislocation, anterior dislocations, which have been augmented with anterior biceps, and the results we will be publishing soon.
Good.
So I agree, the augmentation works.
Inho, you show that you perform the subscapularis tenotomy when doing open bankard. There are some studies that say that there is a deficiency of the subscapularis after that procedure. There were many studies some years ago saying that there is no difference, even comparing to the contralateral shoulder. So what do you think? Which is your experience? Have you had problems with that?
Yes, Daniel, you're very right, because these are all young chaps, and after a subscap tenotomy, once you repair it, I mean, theoretically, you make a shortening of subscap, and then subscap becomes weaker. We didn't have all MRI studies, follow-up MRIs, but some of these patients who had a follow-up MRI, I can see the anterior subscap, the capsule becomes thinner on a humeral attachment side. So I think they have a potential weakness of a subscap. I think that's something you cannot avoid. But what we can avoid is, once you have a good repair of this subscap, try to do a mobilization exercise a bit earlier, and then have strengthening exercise later on, so that you can avoid that rupture.
Okay, yes, I feel, I agree. I feel that the results with the subscap are related to the quality of the reparation that you perform after the tenotomy. Because if we think about the putty-plat procedure that was used for many years, the problem was not that the subscap was not working, was that the subscap was working well, and we have an arthropathy because of that repair. So in my experience, I work with a lot of rugby players, and I have had no problems after partial tenotomy of the subscapularis and repair of the subscapularis.
Great. I think Ivan Wong has some comments on this.
Okay.
Yeah, so I always have concern. I know there's lots of data showing, people who do tenotomy or subscap split, there is, evidence to show that there's no subscap changes. But when you look at the CTs carefully afterwards, and we're doing this right now with our previous ladder J patients, even though we're not detecting it clinically, if we measure by strength dynamometer, if you look at the muscle bulk, there is a change. There's a measurable change. Some people can compensate for it very well, but there is an insult to a muscle. So what we do, we always definitely have to be careful. When we change anatomy, we are robbing Peter to pay Paul. We are trying to stabilize a shoulder using other anatomy that has other functions. We're making a conscious decision to say, look, the subscap may get a tiny bit weaker, but by stabilizing it, by using it as an augmentation, it's going to make the shoulder more stable so the patient will function better, right? So we're making that compromise. So just want you to be aware. You may not detect it. We have to be aware to do the appropriate rehab so that they have minimal sequelae from it, but we are changing what we were born with.
Even I totally agree. I had a few referral cases who had a complete subscap loss after open procedure, which is extremely difficult to deal with. Even though I did some fascia lata graft or something other reconstruction procedure, the result is very, very unpredictable. You are quite correct. Thank you.
Good. Was not my experience. We have not seen problems with the subscap. We take a time to repair it without shortening, and in its anatomical place. And as I said, we have many young sport people dealing with rugby and have no problem, but of course could be matter of a good compensation. We know that internal rotators are very strong and could compensate the subscap. Okay, let's go ahead. Ivan, you have spoken about the lateral shed. We will go ahead with your topic on lateral shed procedure. What happens when open or arthroscopic bunker are not enough?
Perfect. I'm just gonna. Great. Well, thank you very much for having me. We'll talk about kind of a North America experience. We'll go about the lateral J procedure. So by the end of this session, you'll be more familiar with the technique of lateral J as well as arthroscopic lateral J. Hopefully the evolution of this to be able to recreate shoulder stability with recreating the glenoid, as well as management in difficult cases for this. We've already talked about the pathological changes after instability events. There's no question glenoid bone loss is probably going to be number one. We'll talk about that mostly. But when shoulders dislocate, there's problems. They're more than just glenoid problems, right? There's cartilage and degenerative changes. There's humeral lesions. We talked about the bipolar off-track lesions. There's the glenoid capsule that leads to some plastic permanent deformations and elongations of that we have to deal with. The ligaments will change, like that ALPSA, the anterior labral periosteal sleeve avulsion. The labrum will have more extensive damage. We already had discussions talking about getting to 270-degree or circumferential and including slap tears. And we have rotator cuff issues that we need to be aware of, including subscapularis insufficiency, which I'll tell you is probably one of the hardest things to manage. We don't have reconstructions that work quite the same. But glenoid bone loss, let's go back and focus on this. Glenoid bone loss happens, and the question is, how often does this happen? John Dickens in the States has looked at this, and the military recruits get an MRI before they even have shoulder problems. And what they found was patients with first-time shoulder dislocators lose about 6.8% of bone, whereas any of their military recruits that had more than one dislocation had an average of 22.8. So anyone you hear about having recurrent dislocation, be aware, you need to look at this more carefully. And the problem with this is acute versus a late dislocation. Patients having a dislocation less than 6 months have a 27% chance of having a cartilage lesion in the glenohumeral joint already. Those having a dislocation untreated for more than 6 months have a 73% chance of having a cartilage lesion. So patients with longer periods of instability have greater amounts of cartilage damage. We already talked about this engaging Hill-Sachs, so I don't need to go on this, but suffice to say that we need to consider both sides of the bone. Now, what should we do with shoulder instability? Essentially, this paper here in 2018 with Itoy looks at it to say that shoulder surgery really should be considered within the first 6 months of shoulder dislocation, because there are things that we cannot fix. We're going to start changing surgery and changing treatment to be able to optimize their outcome score, just like we're talking about for this lateral J procedure. In fact, the biggest question is, when should we do surgery? Do we do this after the first dislocation? And the easy answer is no, we don't need to treat the patient immediately after his first dislocation. But we should definitely treat the patient before the second dislocation. And I think that's where everyone is getting into, talking about how to predict these future dislocations. Because just like we're talking about now, there's a cost to waiting on surgery after the first dislocation. You're going to change your surgical procedure, and you're going to change the outcome for the patient long term. Just a reminder on the factors, we talked about this instability index. The age is important, male sex, contact sport, hyperlaxity, and bone loss. But the only surgical modifiable factor is bone loss, and that's why we're going to talk about it. We all know this paper from Steve Burkhart in 2000, which says that if there's no bone loss, an arthroscopic Bankart repair works or only fails 6% of the time. But when you have an inverted pair with bone loss, which he estimates probably about 30%, it's a 70% failure rate. So how much bone is too much? And we're talking about this right now. Well, what's a critical bone loss? So Burkhart, a few years later, said it's 25%. This inverted pair based on cadaveric studies is 25%. Shin AJSM 2017 said we need to start looking at this at 17.3%. More recently now, in AJSM, we're looking at 13.5%, including Dickens in his study showing American football athletes with military recruits. And now we're saying off-track lesions and anything more than 10% glone loss, you really need to figure out something else, because soft tissue repairs are not giving the outcomes we really want, and the Hill-Sachs has something to do this as well. And how much is 10%? Well, Preventure put this paper out in 2010. 3 millimeters of bone loss on a glenoid averages 15% bone loss. So it is there more common than we're realizing. And how common is common? Well, you look at the literature that's out there already. Almost 50% of the cases reported in literature have more than 10% glenoid bone loss. So if you're not seeing it very often, it's definitely seeing you. Why is this important? Well, this is the surgical management. I really think this is how we need to start thinking about this. This is a modification of the American Academy template, and looking at both clinical and radiographic outcomes. Those less than 10% bone loss, we're talking about this arthroscopic or open Bankart, just like Professor Inho was talking about, does a wonderful result. But anything more than that, we need to start thinking about glenoid augmentation or bony augmentation, something that's more solid to be able to recreate the static structures of the shoulder. And probably the gold standard that we're already talking about is the lateral J. It's long thought to be the gold standard, and the most important thing of what we do in surgery is we need to have it backed by evidence to know that things are appropriate. This is first developed in 1953 by Dr. Michel Latarjet. Briefly, it involves a transfer of the coracoid to the anterior rim of glenoid, and it works by 3 different methods. The first is a bone block method. The coracoid acts as a graft to increase the anterior to posterior diameter of the glenoid, makes it more difficult to dislocate. The conjoint adds a sling, and this sling is a dynamic reinforcement to the subscapularis, where it moves it inferiorly to limit the amount of abduction and external rotation. So yes, it's meant to decrease range of motion. And the CA ligament repair helps to augment the capsular reconstruction afterwards. We'll get into the outcomes because that's really the most important thing. The outcomes show long-term, 10 years. So there's very few surgical studies that can give you long-term outcomes. And 10-year follow-up, a systematic review looking at 13 studies, 845 shoulders, shows significant improvement. Return to sport rate at 85%. Good to excellent outcome, 86%. Recurrence rate at 10 years, minimum 10 years, 8.5%. Only problem, arthritic change is almost 40%, and we can argue on how that happens. Probably the champion of this, Gilles Walsh, done more than anyone else in the world, looked at his long-term outcomes. Mean follow-up of 20 years, 68 patients with an open lateral J, mean age of 29, and he's looking at all his reported outcomes and shows significant improvement in patient-reported outcomes, and his recurrence rate is at 6% at 20 years, and his arthritis rate is under 10%. So at the best of hands, best technique, most experience, you can get excellent rates. Pascal Boileau, well known for this, he's actually compared the bony reconstruction versus soft tissue. And what he's finding is open Latarjet procedure is more reliable in terms of shoulder instability when you look at this longer terms. Most reported outcomes are 2-year follow-up. And if you look at this graph here at 2 years in his comparative study, level 3 study of almost 200 patients, outcomes of Latarjet, the dark black line, is still improved compared to the Bankart. But you continue to follow this in years to come, and the failures from Bankart or soft tissue repair continue to happen year after year because the soft tissue stretches out. Whereas if you can get a bone reconstruction, the failures happen immediately and then stabilize. The more problem is arthritis afterwards. So no question, Latarjet is the gold standard for shoulder instability with bone loss. You can address the bone loss. You might be able to help with soft tissue as well, but it's not anatomic. You're robbing Peter to pay Paul. You can have complication rates, especially early with neurovascular structures. We talked about the axillary nerve, neurovascular bundles right there. It can progress to glenohumeral arthritis. The systematic review saying upwards of 30% right now, or 40% rather. And probably the most important thing is it is difficult to revise if it should fail because your anatomy is completely changed. Nothing is normal anymore. So Latarjet will trade a decrease in recurrence rate for an increase in complication rate and difficulties with future revision surgeries. So what is there? Well, Laurent Lafosse actually progressed this on to an arthroscopic Latarjet, suggesting that we can increase the visualization of this, allowing us to attack other pathologies that are happening at the same time to improve outcomes, allowing us to see better, because it's really hard to adjust where that graft is in the glenoid to decrease the chance of OA. But unfortunately, you still have to visualize the nerve because you still have to do that subscap split. So this arthroscopic Latarjet really allows us to get those things, get it in a better position, hopefully mobilize it, get it in, decrease the risk of adhesions. And what he's able to find, his outcomes in 2009 of 180 patients, essentially got 88% back to pre-op sports. This is the average follow-up of over 2 years. Excellent outcomes, 91%. Good outcomes, 9%. So almost everyone doing great. His complications are hematomas, graft fractures, nerve palsies, and late complications with graft non-union and graft lysis. So looking at healing from this, he's also looked on with his other colleagues to show that they're getting less and less postoperative complications as they're teaching how to do this. But unfortunately, the French surgeons that's developed this has completely developed all the tools in the beach chair position. I'm a lateral decubitous surgeon. I know half the surgeons around the world are lateral decubitous. So I needed to switch this around. I could not do it in a beach chair. It's a very complicated surgery to do. So we've actually adjusted his technique to be able to do it all in the lateral decubitous to get the benefits of the arthroscopic Latarjet. But the problem we found, was that even though we get better at this, our complication rates did not. He found the same thing. So this is Laurent Lafosse's learning curve paper in 2019, showing that his first 25 cases improved over 5 different surgeons as you learn how to do this. Surgical time improved. However, complication rates did not decrease, and that is the risk of doing something like this. So no question now in 2020, arthroscopic Latarjet, you can have a better rate of instability afterwards. You can reduce those things, but there is a higher rate of intraoperative complications. So you have to be technically good at something like this. Our problem, of course, is that we had very few surgeons. In fact, very few surgeons ever took up arthroscopic Latarjet in the lateral decubitous position, really because of this high learning curve, not addressing the capsule, having difficulty with the nerve, splitting the subscap, having failure of that being difficult, and of course, revision rates being difficult to deal with because the anatomy's changed. So really, we're talking about ideal surgical technique being arthroscopic, anatomic, having a low complication rate, preserving that subscap, addressing the bone loss, and doing that soft tissue repair, just like Professor Inho just talked about. And Matt Preventure in the U.S. really has pioneered doing that, using an iliac crest, a distal tibia allograft to be able to reconstruct this to make it like the Latarjet with the benefits. And the good part of this is that if you can recreate the bone, you can actually simulate the stability of the shoulder just like a Latarjet does, with the normal anatomy recreating the capsule. So this is a randomized control trial study looking at that exact question, iliac crest, so bone graft versus the Latarjet, showing exact clinical outcomes and radiographic outcomes. We've published our technique. We're not going into this, but we're showing that by doing this method of not damaging the subscap, we can have a much faster learning curve than the latter J, probably because we have less portals. So the same type of latter J, we're doing the same approach, but we're avoiding splitting the subscap. And in fact, by doing it in this way, we can actually teach this remotely. This is a teaching module that we had where a cadaveric lab happened in another country using multiple cameras. It's now safe enough to teach this technique to be able to reconstruct the glenoid bone, allowing where to put screws, how to modify it, how to insert it into the shoulder so that another surgeon can do this technique, perform it in their home country without ever having to travel again. Probably why it's beneficial is because we're now no longer needing to change anatomy. We're able to repair the capsule instead of looking at the latter J where we have the coracoid graft there. It's in a great position, but it doesn't stabilize it right away. Whereas we can, using the distal tibia, we can actually recreate that Bankart on top. We can stay away from the nerve by staying within the rotator interval. We've done the study showing that that's much safer, easier to teach to be reproducible like this, and hopefully not having the subscap changes or the worry of a subscap rupture after this type of a surgery. Specific anatomic portals that we won't get into allow us not to damage the subscap like this. But again, the most important thing of something like this is to show the outcomes. And we showed our early outcomes, the 1-year outcomes, by going through the rotator interval to be able to attach this graft. No neurological and vascular issues that we would have with the arthroscopic latter J, with the same healing response as the arthroscopic latter J, with none of the complications afterwards. And this is our 2-year outcomes that we just finished publishing in 2020, showing that we're having excellent fixation, excellent healing, similar resorption rates. And this is what everyone gets worried about, is the resorption rate can be upwards of 50%. But the good part of that is the resorption rate is the size of the glenoid graft at the end is the same as a normal glenoid. And how does this look? Well, this is a 32-year-old female, had it dislocated, reduced and emerged. You can see the pre-op x-rays of that bone loss in the anterior inferior aspect of the glenoid, a pre-op CT with an on-face view with that glenoid loss, 3D reconstruction with that glenoid loss, and that bone actually healed quite medially. You can see more in the anterior plane. This is what it looks like. You can see we just finished talking about first-time dislocators going through. And the most important part looking at this is when we were able to put a graft inside without damaging the subscap, we can actually recreate the size of the glenoid bone. Here you can see from anterior to posterior, that's the size of the glenoid bone. And all I really wanted to show you here is that we can repair this with a Bankart repair like Dr. Ho showed, and that's the edge of it. And why I'm showing you the edge of where the Bankart is, that's the rim of the glenoid. Because now we're getting post-op views showing great reconstructions, remodeling of the bone, which is where people are concerned of, and we can see that the subscap has not lost its volume compared to preoperatively. But now at 6 years, because the remodeling, sometimes the screws are prominent. I do want to show this because this shows how the bone remodels and how it heals in there. She wanted her screws out. The rotator interval that we resected is completely regrown in there. But when we look to take out the screws, we actually have to release the Bankart that's repaired. This is the Bankart completely healed on top of the glenoid. You can actually see the definition between the normal glenoid and the Bankart that's repaired on top of the graft. As I release this Bankart, the important part was this is where that suture anchor was. And I'm just noting that because that was the origin of where the native glenoid is. Everything anterior to it is graft, and this is what it heals and looks like. As we take it down, we're just going to expose this here. I'm just going to get through. But this is the elevation. So using a cautery probe, everything anterior to this suture anchor is new graft. And you can see we've actually recreated, I'll get right to this area. We've actually recreated 7 millimeters of new graft healed 6 years out so that we can actually get this. So removing the screws improved her symptoms, got it back to where it wants to be. So hopefully we've been able to show you that latter J is no question the gold standard for treatment of shoulder instability with bone loss. Open surgery, no question, is reliable, usually successful. has some specific risks intraoperatively that with technical practice you can definitely avoid, but has the risk of post-op arthritis because it's hard to position that graft in the right spot. Arthroscopic anatomic glenoid may be our newer procedure in North America because we're finding it's a similar or faster learning curve like the Bankart, cost effective, allows us to repair the capsule, is safe, doesn't damage subscap, and is anatomic, now showing that we can actually recreate that bone. Thanks.
Thank you very much, Ivan. Do we have any question?
Hi, Ivan. Wonderful talk. Congratulations for your wonderful studies. And can you give us your experience? What the when the graft resorption happens, what would you do? I mean, I had a couple of patients who had a graft resorption after iliac crest graft, and it's very frustrating because we thought it's an autograft and it's going to be healed. But at the end, it didn't really heal nicely. So what would you like to do?
Absolutely. So this is always the question: is graft, and I would use the graft word very generally, because the resorption will happen whether you use, just like you mentioned, iliac crest, coracoid like a Latarjet, or distal tibia. Graft can resorb from anything, and the whole point is that we want to make sure we're doing it for the right procedure. What I think a big problem is there is no bone loss and we're doing a procedure that involves bone grafting, the bone does not get loaded anymore. So the graft doesn't actually see any space, so it will remodel, or I call it resorb, but remodel, not resorb, because bone will always remodel to the point of the appropriate forces. I'm very specifically showing you that case as we were moving the screws, because you saw the end of the graft is round. It's not a rectangular graft like we put in there. So the bone will remodel to anything that sees force. So one of the first thing is make sure that it is not because we did it, they didn't have much bone loss, and really we need a Bankart and soft tissue repair appropriately that way. If it does get lost for whatever reason, its other points is fixation. So if we do a soft fixation, like a suture type of fixation to get the graft in place, has a higher chance of remodeling and going away, because if there's too much motion, bone doesn't heal. It needs solid fixation, just like principles of fracture reduction. If it still goes away, the only good part of using an iliac crest is you have not damaged the coracoid or the conjoint sling. So the appropriate treatment for me, if I see someone with an iliac crest type of a bony reconstruction that's failed, I can now move on to a Latarjet procedure where I will transfer the coracoid to the anterior rim of the glenoid, and not really concentrate on the bony reconstruction per se, because if I'm worried about remodeling, it might remodel with the coracoid, but I'm really using the other two anatomy that I'm actually moving. I'm using the conjoint sling, I'm using the subscap shift, and I'm using the CA ligament reconstruction.
So again, we have to be careful. It's a matter of terminology. Rather than saying resorption, we better to use remodeling of the graft. Correct?
Absolutely.
Thank you. Yeah.
Good. Any other question? So we see that many different techniques are appearing. I feel that some of them look to have a compensation of the deficiencies of the techniques that were used before, that they were said that they were the perfect techniques, and we see now that there is no perfect technique, but it is the process of evolution. And in this process, we have another option, that is the use of bone graft that has developed in the last years with several techniques. And Dr. Guido Fierro from Colombia will give us a lecture about that.
Thank you, Dr. Moya, and thank you for all the panel for this kind invitation. Actually, I think Ivan just resumed half of my talk, but I'm trying to explain a little bit with more numbers about this topic. I'm going to talk about, as Dr. Moya said, about the reconstruction of the glenoid using iliac crest bone graft. And when we think about this topic, we think in biomechanics, and you Google, and you go into PubMed, and you try to find papers about this topic, and you find, in my opinion, three groups of papers: biomechanic papers about technique and videos, as Ivan just showing us very well, and the results. I mean, what happened when we put in practice the biomechanics and technique, and about the results, it's what I'm going to talk in this talk. I have three questions for answer. If this technique is safe and effective, what is the clinical and radiological long-term results, and what happened if we compare the iliac crest against the lateral jet? Okay, it's safe and effective. Actually, Ivan just published this paper. I'm going to show paper from the last 3 years. It's a short follow-up, 1.4 years of follow-up, 13 patients. And what they found, the authors showing us, is that all the patient improve in score, the movement improve, the instability improve. They didn't find any dislocation or apprehension, no intraoperative complication, no neurovascular injuries, no infection, no major bleeding, and just have one partial graft non-union. I mean, looked at it is effective and safe. But what happened with the resorption or remodeling of the graft? Look, 10 of 12 patients have less than 50% of the resorption of the graft, and one have more than 50% of the resorption. But it's a lot of patients with the remodeling of the graft, but without a clinical implication because the patient remains stable in this paper. This is another paper, 5-year follow-up, 24 patients with a glenoid defect from 22%. The technique is similar that we use right now, and all the patient improved in all the score, but the internal rotation was the only movement that was decreased if we compare it with the other shoulder, and 13% show excessive graft absorption. I mean, the absorption is a problem, and look, here appear another problem, and is the other osteoarthritis. 50% of the patient increase the grade of the osteoarthritis in the Kellgren-Lawrence classification. I mean, it's absorption, remodeling, and arthrosis. This is another paper, 15 patient, 1-year follow-up. None of those patients show subluxation or redislocation. 11% was a complication, but not a big deal. It was just hematoma and reduced sensibility over the iliac crest. And none of those patients show resorption, but those patients, 35% show mild osteoarthritis. I mean, this is a other patient, or other study, 22 patients, and compare allograft with autograft. And looks like the logical say that it's better if we use autograft. In the Oxford score, show that it's better the autograft than allograft, and the resorption is more resorption in the allograft group than in the autograft group, and the non-union rate was higher in the allograft group. Okay, this is, looks like it's effective, the surgery, and it's safe, but could increase the osteoarthritis. And what about the clinical and radiological long-term results about this technique? This is a paper with a huge follow-up, 18 years, 34 patients at the end of the follow-up with the J-shaped graft technique. Use it, and looks like all the patients improve in the movement, improve in strength, and it's almost similar than the contralateral side. They have just one redislocation. 77% of the patient has apprehension and relocation test negative, and just 5 patients has a hypoesthesia at the iliac crest. But almost all the patient was satisfied, and no correlation between preoperative factor and clinical outcome scores. It looks like it's it is still effective and safe. But looks here, looks this graphic. The normal joint space was just was the 77% of the patient, and narrowing in this 23%. Look like a 25 patient has osteophytes, and in the CAA score was 0.9, and if we compare with the contralateral side was 0.4. I mean, look like this technique, or maybe the trauma in the shoulder increase the probability to have osteoarthritis. Look, in the affected side, they find that no sign of instability arthropathy in the 26%, and in the contralateral side was 69%. And it looks like a huge difference between the affected side and the contralateral side in terms of the osteoarthritis. This is another paper with 5 years of follow-up, just 14 patients with autograft, and they show just one dislocation, improve in the scores, improve in the movement. But look, this is what we were talking in the discussion before, the graft remodeling, and try to adopt the pear shape of the glenoid with the follow-up. This is another paper with 3 years of follow-up with autograft, with fixation with bottoms. And again, looks like all the score improve in movement, improve in strength, improve in the recurrence of dislocation. I mean, they find that there's no recurrence in their patient, no subjective shoulder instability, no major complication, and the postoperative shoulder range of motion was almost equal to the contralateral side. I mean, at this point, this technique looks fine, effective, it's safe, and the result, and in the long term, is a good result. And what happened if we compare this technique with the lateral jet? Dr. Wong just told us about this study. Was 60 patients, was randomized, and look, all the score improved in the same way. I mean, all the were no different between the lateral jet or the iliac crest, except in the internal rotation was the only point that the lateral jet was inferior than the iliac crest. And look, the complication was a heterogenic complication. In the iliac crest, the problem was more in the donor side, and the lateral jet was more that scapular dyskinesia. And it's no different in pain and satisfaction. I mean, at the end, our question is, this technique is effective and is safe, can increase arthropathy. That is a theory, because actually I'm not sure it's about the technique or about the disease itself, and is effective as lateral jet. Thank you very much.
Thank you very much, Guido. Very interesting, and another option. Do we have any question? So, which is your choice today when you have a bone defect, Guido? How do you proceed? Do you consider lateral jet?
Yes, actually, I use not just iliac crest. I use distal tibia or distal clavicle too. I mean, I really like distal clavicle because it's in the same area of surgery, and in many patients you have enough bone to feel the defect. I mean, when you think about the defect, you always think about 30%, 28% of the defect. But many patients have 18%, 50%, 30%, and in those patients, the distal clavicle works fine too, or distal tibia. I just try to use iliac crest in revision for lateral jet. I mean, I did it one time with a patient with a lateral jet that was failed because of other problems, and I used the iliac crest for this patient. Otherwise, I prefer distal tibia or clavicle.
Thank you very much. Do we have any other question? If not, we will go ahead with my presentation. Well, I will speak about the different condition. It is I show glenohumeral instability, but multidirectional instability has very controversial points of view, and also it is really a challenge for orthopedic surgeons because it's a complex condition. Erika mentioned this paper, even though the multidirectional instability or the traumatic instability, in fact, was described initially by Hippocrates more than 25 centuries ago. The first time that we have a clear presentation of the problem, I agree, based in a technique more than in the clinical examination or in the condition itself, was by Neer and Foster in the 80s. And at least this put the topic in discussion for the big audience of shoulder surgeons. In the 90s, we got another possibility to see the different types of instabilities, thinking about the TAPS and the AMBRI, the traumatic, the atraumatic, and fundamentally two types of patients. The patient with a normal shoulder that after a trauma develop an instability, and a patient with a predisposition to develop this type of instability, which the extreme example was the Ehlers-Danlos disease. The Baton score was considered important to detect the laxity and hypermobility, as we all know, and it became very popular. But there were some other tests like the Sulcus test. We can see here in this same patient the thumb sign. So we used to face this kind of cases, and there were even described different tests like the test described by Gerber, that it was the anterior drawer test and posterior drawer test. But we also have the chance to see this type of people. This was a medical student with no symptoms, that when I was talking about multidirectional instability, she showed me what she could do, but she had no problems with her joints. So we began to think, well, which is the threshold between the normal people and the people that have problems? We know that there is a big variety of levels of laxity that can be influenced by sex. Women generally have more laxity than men, age, younger people, and even race. There have been shown that comparing different countries, there are different levels and percentages of laxity. We also know that for some sports, hyperlaxity or hypermobility is kind of an adaptive reaction of the joint, for instance, in swimmers or in throwers. So in these cases, could not be a pathology. And these papers were very interesting. One by Emery that states that general joint laxity was not an important characteristic of patients with positive signs of instability. And on the right, you can see that the laxity, the magnitude of glenohumeral translation is not a specific test for the diagnosis of glenohumeral instability. So as Erika said, the use of laxity tests by themselves and generally lead us to an overestimation of patients suffering MDI. But we also know that there are many patients with MDI that are not diagnosed. So we have both extremes in the daily practice. All these discussions led Emery to ask if MDI does really exist. And I think that a classification that gave us much more information about this, and for me it's a very interesting tool to work with, is the Tammore classification, because in this triangle made by Bailey, it gives us the idea that the patients are not TAPS or AMBRI, but there are a lot of gray areas in which the patient can be located. And we can also see that patients during the natural history of their instability can move from one point to other point. There were also many years ago ideas about the rehab, just thinking on the capsule and thinking about the hyperlaxity. And Rogut, that let's use this paper as a homage to him that passed away 3 weeks ago, published with Wayne Barhead this paper that I feel is a very important paper in shoulder surgery, because give us the option of using rehab to treating instability. And generally, we surgeons, we do not take time speaking about these topics. They treat a group of patients with shoulder instability with a rehab program, and they realize that they have good results in atraumatic instability, especially in posterior inferior instability, better results in the absence of dislocation, no difference related to age, sex, and evolution, and also report bad results with traumatic instability, especially if there was trauma and dislocation. Also, surgery used to look just to the capsule, and techniques, the most popular techniques were inferior capsular shift, then arthroscopic plication, and thermal capsularraphy, but always thinking about the capsule. But there are other structural factors that are related to instability and play a role in the etiology of multidirectional instability. And we must consider the rotator interval, the inferior labrum, and the glenoid version. As we know, the rotator interval has a very important role in inferior and posterior stabilization of the shoulder. Sometimes we found an insufficient in rotator interval. We make the application of the rotator interval during the surgery, but sometimes it is even not enough, and we must go ahead with reconstruction. And the coracoacromial ligament is used in some cases to reconstruct the rotator interval, as we can see in this cadaver in which we perform that technique. What about the inferior labrum? We know that it has really a lot of importance in keeping instability. It is the deeper area of the labrum, and they have been described specific lesions that can appear in patients with multidirectional instability, for instance, Kim lesion in the posterior inferior labrum, that we should consider when treating these patients. The jerk test and the Kim test are good options to evaluate the posterior inferior labrum, and the combination of both of them have a very high sensitivity to detect posterior inferior labral lesions. What about glenoid retroversion? Well, in some patients, it is important and it is a factor to be considered. Fortunately, it's not common, but we should also evaluate the retroversion when dealing with patients with multidirectional instability. But not all are structural factors. There are also functional factors that we have underestimated for a long time. And we must consider in these patients the presence of changes in muscle activity, altered corticospinal control, improper scapular positioning, and abnormal muscle recruitment. And that is a very important point, because we know now that the neurology has a lot of importance in the type of instability that these patients develop, and that we will not be able to correct all the etiologic factors using the scalpel. We need to know that there is another area, another universe that was there for a long time and we did not recognize. That's why I think it is very important to consider the Stanmore classification, because they make a point about the polar type 3 instability, in which there is laxity, but there is also a alteration on the muscle patterning. And if we treat these patients as we used to treat with rehab, the type 2, just patients with laxity, may strengthening the muscles, we will just make the problem bigger. Rehab is still the first choice in patients with multidirectional instability. We stabilize the scapula, we strengthen the rotator cuff, we must treat the corticospinal dysfunction, improve proprioception, but in some patients, it may be insufficient and we need to move ahead to surgery. I want to make clear that, for instance, Dr. Rockwood used to treat these patients with rehab in cases of posterior inferior instability for 1 year before considering that rehab was not working, because we know and we discuss this with the patient at the beginning of the process of the treatment, that we have a long road to walk together. I want to show you a case in which this was not enough and we needed to go ahead with surgery. It was a 42-year-old female with a bipolar disorder treated with lithium, and this is something that is frequent to have some psychological associated problems in some of these patients. This lady used to have several episodes of instability every day, and even she used to faint in the street when having the instability episodes. She was a single mother of a 18-month-old daughter, so there was not just her personal problem, was a social problem as well. And she had a long history of problems with her shoulders, but no big problems. Till in 2002, she had a traumatic episode on her right shoulder, and she was operated with a diagnosis of acute bursitis. And this is a good example of how many times MDI is not recognized, and some surgeons treat the consequence of the MDI, perhaps the most evident consequence, because in many cases instability is very subtle. But this patient kept on having problems, and the shoulder was getting more and more unstable till she developed a voluntary and positional instability. When I first examined her 6 or 7 years ago, she had on the contralateral shoulder a very clear laxity, very clear sulcus sign. And during this first consultation, she had 3 episodes of dislocation, just spontaneous dislocation. And fortunately, she didn't faint. You can see here, this was recorded by her. You can see what she can do with her shoulder, and she, as you see, have the chance to voluntarily dislocate her glenohumeral joint. So what to do? Well, we try rehab, and I can tell you that the one who almost fainted was the physiotherapist, because dealing with this lady was very difficult because of the amount of instability. The MRI was showing a lesion, perhaps it was an injury of the labrum. There was not clear. We discussed this with a very experienced radiologist, and was not clear if there was a lesion or not. There was a very small Hill-Sachs lesion in the CT scan, and no more than that. As you see, in many of these cases, the studies are almost normal. So we decided, with the approval of her psychiatrist, to go ahead with surgery. The diagnosis was a polar type 3 instability, and we performed an arthroscopic evaluation. The labrum was intact, was no problem, was not necessary to perform nothing. We evaluate the anteroinferior labrum and the posterior inferior labrum, and then we operate in beach chair position, perform an open capsule application and closure of the rotator interval. This is the procedure that InHo have shown. We develop two flaps, a medial flap that goes laterally and up, and a lateral flap that goes medially and also goes cranially or cephalic. And this was the result. Fortunately, the patient, we get involved as surgeons in her follow-up and her rehabilitation. As you can see, it's not a big incision in these patients with such laxity. It is easy to get even to the rotator interval with that incision. And fortunately, she had 7 years now of surgery and is doing well. So MDI exists. It is multifactorial, and we must consider not only structural changes, but also functional problems. Laxity by itself is not as essential as we used to think many years ago. We must consider neurological disorders associated with these patients. Rehab is of fundamental importance and generally is our first choice. I feel very comfortable with open capsule application because it is a very solid construction. We overlap the capsule. We cut the capsule and overlap the two flaps. The posterior inferior labrum should be evaluated, and in some cases we should consider the shape of the glenoid and think if it is necessary to perform an osteotomy. Fortunately, I did not face one of these kind of patients yet. I don't know if you have any question about this.
Yes, I have a question, Dr. Moya.
Yes.
When you close the rotator interval, do you pass the stitch through the subscapular and supraspinatus, or just in the interval?
No, just the interval. Our first step is to close the interval, and then we close the capsule, the capsulotomy that we perform. So no, there are two different levels. One level is the capsule and the rotator interval, and then we reattach the subscapularis without shortening. Okay.
Thank you.
Sure.
Daniel, one quick question to share with our audience. You presented nice, good polar type 1, 2, 3. So just like to ask all the other speakers, especially Ivan Wong from North America, what do you think about the TUPS and the embry? Is it still a viable, diagnosis definition, or is it already old, dead concept? How do you understand that embry and the TUPS, the lesions? Daniel, can you?
I thought you were speaking to Ivan. I think that the TAPS and embry are a description of reality, and you have patients that are TAPS and you have patients that are AMRI, but it is a partial description of the reality. We have a lot of patients in between TAPS and AMRI that were not described by that classification, but I feel that it was a very important step in the evolution of the knowledge of the classification of glenohumeral instability.
Yeah, I'd have to agree. It's really important to think about it that way. All these classifications, the more classifications you have, the more you realize how complex a problem this is. I think essentially this just highlights that we have two main problems. We have the bony version, right? We had a long time talking about it, and Dr. Moya is very graciously describing the soft tissue part, because the soft tissue, unfortunately, is even harder to deal with than the bony side because it changes over time. And you have to be able to take into account nothing is a static definition. And unfortunately, this soft tissue is not just the capsular part, right? You have the dynamic part of the soft tissue, and that's where it comes into. And we don't have a perfect classification. This is the art of medicine, where we actually have to combine all of these things together. And as we develop better and better options and techniques, and hopefully having the clinical outcomes with it, we can address each of these in isolation, so that we can make the best possible outcome for that specific patient. Because even though the anatomy may be the same between one patient and another, the ability for us to execute the surgery and the expectations of each and every patient is different.
So Daniel, one more question to you. How often you do this multidirectional instability surgery in your clinical practice?
No, it's not often. Most of the patients have a good result with rehab. And the last patient I operated on was 19 years old patient that I, in fact, met yesterday. I operated her 1 year ago, and it was in fact a reoperation. She was, it's a very interesting case. She got arthroscopic surgery, very big anchors. One of the anchors were, two of the anchors were out of the bone, and so and she had the same instability that before, positional and voluntary instability. The first time she came to my office, she was sat and moving her shoulder in a way that was very similar to the patient I showed you before. And again, we perform the application of the capsule, the closure of the rotator interval, and we were able to extract one of the anchors. Another of the anchors was in bone, so was not necessary to take it. But the third anchor was in the area of the axilla, and we couldn't see it when we performed the arthroscopy, and we decided not to go ahead and take it because it was really very dangerous. I received an X-ray because fortunately they are metallic anchors. We check. I asked her to take an X-ray every 1 year, and everything is okay, and she recovered her stability. She asked me permission to begin playing, having yoga and swimming in a very intensive way yesterday, and I allowed her. But again, there are patients with a very special psychological way. She's a medical student, and they ask me to keep on being in touch, that she needs some, I would say, psychological support. So they are very special patients. Okay, I think we are on time. Fortunately, we did all this that I really learned and enjoy a lot. In the exact time, Dr. Ashok, our boss, is here. So what do you think, Ashok? Are we okay with this?
Yes, I think it was a brilliant webinar that we have conducted. Excellent presentation by all faculty. And Dr. Akshay will be presenting the vote of thanks on behalf of Viro Global. So over to you, Dr. Akshay.
Thanks a lot, Dr. Ashok, for providing the platform for getting all the stalwarts from across the globe on a common platform, and especially addressing to a esteemed meeting such as VIROC, which is conducted in Mumbai, the home turf. I'm very grateful to Professor Daniel Moua, Dr. Yvonne Wong, Professor In Ho Jeon, Professor Guido, Dr. Erica, Dr. Hani, for being a part of this wonderful discussion and academic feast for shoulder instability discussion. This was indeed a wonderful session, and I think a lot of surgeons in India and across the world, especially on this Viro Global platform, will get benefited with the discussions and the presentations here. Thanks a lot.
Thank you very much.
Thank you very much.
Dr. Akshay.
Thank you.
Okay. Any
Okay.
closing remarks, Professor Inho?
Oh no, not much from my side. Thanks very much for your time, guys, and hope our audience and participants enjoyed our talk. Thank you very much.